Okay, welcome back, DPT 23, and we are now going to continue with our wheelchair lecture. So, when we consider fitting a wheelchair for a patient, we will obviously need to consider the size of our patient compared to the size of the wheelchair and uh, make sure that there's a good fit. So, the one point on this slide I want to illustrate is this 90-90-90 rule, and that's basically talking about hips, knees, and ankles, just trying to have all of those joints at roughly 90 degrees as kind of a framework, if you will. Um, so seat depth and seat width. Well, here's a slide here coming up about sacral sitting. Here's what it is. Basically, on the picture on the left, the patient is slumped and their pressure is not on their ischial tuberosities. Their hips are not at 90 degrees. Problematic. So we go back here. We want to be aware of sacral sitting. We want to hopefully leave 2 inches from basically the back of the hips to the bend of the knee, and we want 2 inches of kind of clearance or space there. And same with width. We want 1 or 2 inches on each side of the patient so that their greater trochanters are not in contact with the side of the wheelchair. Um, Seat to floor height, basically same thing. We were trying to have the ankles at 90 degrees, and so this whole 2 inch rule, we want 2 inches between the end of the wheelchair and the distal thigh or the knee joint. We want 2 inches on each side where the greater trochanters are, and we want 2 inches uh, with the from the ground. So the ankles are at dorsiflexion, 90 degrees of dorsiflexion. Um, Seat back height, that's going to depend on the wheelchair and the height of your patient. We would like to have 4 inches below the axilla and the top of the seat back. Obviously, if there's more than that space, the center of gravity could be high for the wheelchair. If the back is too low, then they can be at risk of coming out of the wheelchair backwards. Armrest, we want to have the elbows at 90 degrees whenever possible. We want to make sure that, and there are some patients that have specific needs. The first example that comes to mind is a patient with a hemiplegic upper extremity, and so they have kind of like what we call them a trough that slides onto the top of the side rest of the wheelchair, and it's basically kind of just like the name says, a trough for their arm to rest in, and it just provides stability. And because of often the lack of awareness that a patient after a CVA has experienced of their involved upper extremity, it keeps that arm safe. A lot of patients in that situation are completely unaware of their involved upper extremity, and the arm can end up dangling off the side of the wheelchair, putting that arm at risk. So um, that's a special adaptation of armrests. And so this is kind of how we can use the two-finger confirmation of making sure that the wheelchair fit is adequate. So once again, the between the hip and the side of the wheelchair, between the front edge of the seat and the popliteal fold or the bend of the knee, between the front surface of the wheelchair and the distal thigh. Anyway, so this is all quite, I think, obvious and logical as far as just making sure the patient has space, but not too much space in the wheelchair. If a patient wheelchair is improperly fit, these are problems that can occur. You can look through these and it should be pretty self-explanatory. Seat is too, for example, we'll just go to the third one down, seat width. If there's too much width, their arms have difficulty going around the sides of the wheelchair to propel themselves. If it's too narrow, then there's pressure on the greater trochanters and so forth. Uh, so patient and family education, we want to make sure that, especially for those patients who are at risk due to cognitive impairments and or sensory deficits, to make sure that skin inspection is a regular occurrence. Often that needs to be put on a schedule. Just because they have a wheelchair cushion, even a state-of-the-art wheelchair cushion like the Roho or a gel cushion, that doesn't mean that they don't need to be checked for specific uh, bony prominence areas, and also just in general the lower extremities to make sure circulation is normal. Um, so all the different additional components of wheelchairs. Some wheelchairs have anti-tip levers in the back so that if they are, and this would likely be for a patient with cognitive impairment so that they can't do a wheelie and fall over backwards. It basically prevents them from tipping back. Sometimes wheelchairs, in addition to the brakes, there are locks that can be put on the wheels so the patient cannot self-propel, because sometimes with cognitive deficits that becomes a safety risk. Sometimes there are different kinds of straps or belts used to help position the patient in the wheelchair. And the other things are normal parts of the wheelchair. The caster wheels are those two small wheels on the front that pivot and rotate. And then we've already talked about the hand rim, which is how the patient propels him or herself. Uh, Sometimes for armrests, there will be guards so that if the patient has long hair or long clothes, it can't get caught up in the wheels. And then leg rests, sometimes they have foot plates that are used, sometimes they're not. So now we'll talk about some of the basic propulsion for patients who are dependent. So basically, we as a clinician will be moving the patient and often educating caregivers or family members to assist with this. So one of the first things to recognize is that second bullet point. And this is something that hopefully in our lab on Monday you will get. If you haven't had it before, you'll have some opportunity to uh, spend time in a wheelchair and consider it from the patient's perspective. If you are pushing a patient in a wheelchair, especially a patient who's older and or who has health issues, uh, don't go too fast. Remember that you're moving a human being, and it's easy to get caught up in and forget that and be in a hurry to get the patient down to therapy or wherever you're taking them, and go too fast, and it can be very fearful for the patient. So make sure that you remember this is a human being that you are helping to move, and so be aware of their safety and how they are experiencing all of this. Of course, brakes are incredibly important. A lot of patients are very vulnerable who are in wheelchairs, and if we are charged with moving them in the wheelchair, we need to be hyper vigilant of their safety. And of course, the first bullet point, good body mechanics. We want to make sure that we're protecting ourselves, especially when we're going up and down curbs and ramps and inclines. We need to use our legs and protect ourselves. So when they are on uneven surfaces, obviously propulsion can be more difficult, and sometimes the large wheels in the back are going to navigate grass or gravel or sand better, and so tipping the patient back and getting those small caster wheels off that surface will help to move the wheelchair. Now, the quote unquote clock on the wheelchair that will be referred to on the next slide is basically talking about the hand rims where the patient will propel oneself, and the very top of the handrail would be 12 o'clock, and halfway down the front would be 3 o'clock, 6 would be the bottom, 9 would be halfway in the back. So when we're instructing patients to propel themselves, we want to start at 10 o'clock, so they're going to reach back, not quite half the way down to the back of the wheel to the 10 o'clock position if that hand rim were a clock face, and propel forward to 2 or 3 o'clock. So obviously, if they're having to reach back further beyond 10 o'clock, that's going to put their shoulders potentially at risk. And if they go further than 2 or 3 before they release, that's going to potentially have them leaning forward too much. And so we'll show you this in lab to make sure you understand. Wheelies are used, definitely a higher level maneuver for a lot of patients who spend a significant amount of time in a wheelchair. A wheelie can be not just a fun showmanship type of thing, but instead a very functional practice to allow them to go off a curb or off a raised area and through difficult terrain. A wheelie is often a desired way to maneuver. Typically in this wheelchair lab, we have 1 or 2 students who are practicing a wheelie and fall over and hit their head. I'm thinking of, I don't know why, Joey Mack. I don't know why he comes to mind. Daniel, Munoz/Travis Scott also could be potentially at risk. So please, when we are ourselves learning about wheelchairs, be very careful. And if you want to practice a wheelie, be careful and do not hurt yourself. So powered scooters, we talked about these a little bit earlier, and obviously your patient's cognitive status is very important. You want to make sure if you are in charge of teaching a patient how to use a powered scooter, you want to make sure they understand how to control their velocity, how they brake, how they turn, and approach a table, for example. So again, cognitive status and judgment are very important, and we want to make sure that we take all those things into consideration when we're training a patient about the use of a wheelchair. So a lot of this we're going to do in lab, and we don't. And the book textbook also talks about a lot of these different scenarios. This is just one way. When you are helping a patient go through a door, you can back the patient through the doorway. And once you're almost through the doorway, you're using your left foot in this picture to keep the door open while the patient clears the doorway. Need to be aware of how much clearance you have with their feet. Often patients who are in wheelchairs are not wearing shoes. Often they have one lower extremity that's been injured. Maybe they had surgery on their foot or ankle. So you want to be careful not to whack their post-surgical foot into the door frame or their unclothed foot that's not in a shoe. You want to be very careful that you are providing enough clearance and not closing them in the door or hitting them on the door jamb. So when a patient's coming through a door independently, here's an example of how they will wheel up to the door, push it open with their arms, and then basically the wheelchair will help the door to stay open. And depending on the patient's ability level, they might be able to zip right through the door before it closes on them. Going in a door, similar. This would be a great thing for each of you to spend some time at any time when you want, when you have a moment on campus to get in a wheelchair and practice going through doorways. That was part of what the ADA, American with Disabilities Act wheelchair assignment was to allow you to experience, is this kind of life from a wheelchair and how you access businesses, doorways, and so forth. So depending on how much time you get in lab, maybe you want to take some extra time on your own to have some wheelchair experience. This is invaluable as you are working with patients to have been there once. And I'll just make a tangent comment here. When a patient's in a wheelchair and we are standing above them, that can put them in a very vulnerable type of situation. And so often it's so valuable to take a knee next to them so you can be on there, or sit next to them on a stool or in a chair to talk with them so that you're not standing above them talking down to them. But very often that small effort of putting yourself at eye level with them really helps your communication efficacy quite a bit. Ramps. So the ADA, sounds like a test question here, dictates that for every 12 inches of incline, you need at least 1 inch of, I'm sorry, for every 1 inch of incline, you need 12 inches of ramp so that the slope is not too extreme. And the maximum amount of elevation change is 30 inches. On a given ramp. So that's why you see on the outside of several businesses ramps that seem so long and so gradual. But of course, it's for safety and just for a patient's ability to self-propel up an incline. If it's too steep, it's going to be unsafe and or impossible. Okay, so when a patient is ascending or going up an incline, we want to keep all four wheels on the ground, and if needed, we can kind of do switchbacks to avoid the severe slope. And the patient can shift their body weight forward, and they can help on the hand rims if needed. When they're going down an incline, we want to go backwards, and hopefully this is logical, because if we go forwards down a steep incline, a patient can fall right out of the chair, and or it can be very terrifying for a patient to feel like they might come out of a wheelchair. So that's why we would go backwards. And this will conclude part 2. We're going to be back in a minute with part 3. Adios.